Suboptimal. My name is Bethany Hopkins. I'm a Medical Affairs Manager with Nestle Health Science Canada, and I'm pleased to be the moderator for today's session. Before we get started, I would like to go over a few items so you know how to participate in today's event. Next slide, please. As you can see from the image on the right, we have taken a screenshot of the attendee control panel. You should see something that looks like this on your own computer desktop in the upper right corner. The first thing I'd like to draw your attention to are the audio options. If you've joined the presentation listening using your computer speaker system and would prefer to join over the telephone, simply select Telephone in the audio pane and the dial-in information will be displayed. Next, should you require technical assistance, please type your question into the question panel to the right of the screen and our Citrix representative will assist. You will use this same question panel to ask questions during the presentation. As a participant, your audio is on mute. However, you will have the opportunity to submit questions at any time. I will be collecting all of the questions for the presenters, who will address them at the very end of the presentation as time permits. In addition, I want to make note that there are two handouts for today's session. One contains the presentation slides, and the other is a certificate of attendance. You will download these documents directly from the control panel. When referring to the handouts, you will find several additional slides on muscle mass and muscle wasting. These slides will not be reviewed live, rather they provide additional background on the subject that may be of interest. And lastly, I would like to note that today's session is being recorded. Next slide, please. Now it is my pleasure to introduce our presenters, Dr. Darren Hyland and Kathy Alberta. Darren Hyland is a professor of medicine and epidemiology at Queen's University in Kingston, Ontario. He is trained in internal medicine, critical care medicine, and clinical epidemiology. He currently serves as the director of the Clinical Evaluation Research Unit at the Kingston General Hospital. He is principal investigator on a number of large-scale, multi-center clinical nutrition research projects, lead author of the Canadian Critical Care Nutrition Practice Guidelines, and sponsor of the International Nutrition Survey. Dr. Hyland has published extensively and is sought after as a presenter. As many of you know, Dr. Hyland has been a leader in driving evidence generation, knowledge translation, and practice change in the critical care nutrition community, both in Canada and around the globe. In this webinar today, Dr. Hyland will review evidence suggesting protein provision has the potential to improve the recovery of critically ill patients. Insights regarding current practice and the need for ongoing quality improvement initiatives will be explored, along with further research implications. Our second speaker is Kathy Alberta. Kathy received her undergraduate degree from the University of Saskatchewan in Saskatoon and a master's degree in nutrition and metabolism at the University of Alberta. For over 20 years, she practiced as the critical care dietitian at the Royal Alexandra Hospital in Edmonton. Currently, she is clinical nutrition program lead for acute and rural hospitals in the Edmonton area. Her research interests include probiotics in clinical care and the nutritional requirements of critically ill patients. Kathy has collaborated with Darren Hyland and the Critical Care Nutrition Group and is passionate about nutrition education, research, and integrating the practicing dietitian's voice into the critical care dialogue. Today, Kathy will share results of a recent quality improvement project which demonstrated use of a specialized higher protein enteral formula can help achieve higher protein targets in critically ill patients. Practical insights and key learnings will be shared from a dietitian's perspective. I will now turn the floor over to you, Dr. Hyland, to begin the presentation.
Well, greetings all. Thank you, Bethany, for that introduction, and thank you and your company for supporting this initiative. It's wonderful to get together as a critical care nutrition community across Canada. Although I can't see anyone, I'm sure there are some familiar faces out in the audience, and gosh, I really thank you all for your support and interest in our work over the years. It's been wonderful to collaborate together. It's also very special to be on this program with Kathy, as I was a critical fellow many, many years ago when I first met Kathy, and she was instrumental in stimulating that interest of mine in critical care nutrition. So as Bethany alluded to, I want to talk about protein prescription, protein delivery in the context of critical illness, and I'll briefly introduce the notion of how important retaining muscle mass is for critically ill patients, and the role of our macronutrients, in particular protein, on muscle and muscle-related outcomes. That will lead us into a conversation that maybe protein isn't important in all critically ill patients, and we'll get into this concept of nutrition risk assessment, and I'll elaborate on where we're at with the Nutrix score, which I'm sure many of you have heard about. And then finally, as a segue into Kathy's presentation, we'll talk about strategies to improve protein amino acid delivery in the context of critical illness. So we situate this story in what is evolving into a very large story about survivorship over the last few decades in critical care as more and more patients survive, and as we see more and more patients, now we're turning our attention to their recovery from critical illness, and we're describing ICU-acquired weakness and related syndromes, which are very prevalent in our patient populations, and depending on the case mix group, it could be up to 100% of these patients suffer from ICU-acquired weakness. And there's been some really good statistical analyses that have compared the outcomes of patients with and without this ICU-acquired weakness and have delineated how much attributable burden there is associated to developing weakness, both from a clinical point of view, what the patient experiences, but also from a systems point of view and how much increased resources it requires to attend to this problem. And so it just underscores the importance of trying to figure out what is this problem with weakness and how do we both prevent and treat it. And of course there's a relationship directly between weakness and muscularity or muscle atrophy. And what I'm using in this slide is to summarize several slides that are included in your handout where we and others have begun to characterize that upon admission to critical illness, many of our ICU patients are already sarcopenic, or rather have low muscularity. And that low muscularity is a problem. Number one, it's associated with poor clinical outcomes, including the traditional ICU outcomes of mortality and length of stay, but also it is related to physical dysfunction and increases the struggle that these patients have with their survival experience, limiting their abilities to return to an active or at least a normal pre-ICU life. But also remember that muscle is the bed where we dispose of glucose. And so if we're low on muscle mass, that may have implications for glycemic control. And it's also the source of many amino acids that contribute to our immune system. And so again, there's a relationship there with immune dysfunction and increased complications. It's not that patients just arrive in our ICU with low muscularity, but also, as we have characterized in several studies, patients lose muscle mass over time. And the real question for us is whether we can preserve muscle mass and improve patient outcomes with our feeding strategies. And in particular for today, we'll talk about protein. And I'm not really asking the question in a yes or no way, does protein, yes or no, impact patient outcomes? Because I think we all give protein, we all believe in the concept, and there's data to support that. But rather, I want to frame the question, does giving more than is being currently prescribed and happening, is that impacting outcomes? And I think that'll become clearer as I go through these next series of slides, which on the x-axis delineate the, in this instance, amino acid intake with an increasing dose up to 2.5 grams per kilogram per day. And what we're showing on the y-axis using elegant tracer studies is the whole protein balance across the body in critically ill patients. So this is from Olav Royaker's and Jan Werneman's studies, and there's several studies involved in this slide, but what it's showing that as I increase the amount of amino acid availability or delivery in an ICU patient population, that is having a favorable effect on protein balance without excessive oxidation, which is on the slide on the right, which is good. I mean, we don't want that protein to be utilized as fuel, but rather incorporated de novo into protein synthesis. Similarly, as we increase protein intake, so the same x-axis, but now the y-axis is nitrogen balance, and so this is actually showing a more favorable effect on nitrogen balance as I push up the protein intake. This slide shows the effect of protein intake on muscle mass. Oh, maybe that slide's not projecting well. Oh, wait a minute, there is no evidence that increasing the amino acid protein impacts on muscle mass. So I flagged that as a gap in our knowledge, and probably because we struggle with adequate measurement of muscle mass in the context of critical illness. As you know, we've been doing some opportunistic work with CAT scans, and we're trying to validate ultrasounds, but that work's still premature, and we don't see, or we don't know, what the relationship between protein intake and muscle mass is. But let's move on and talk about the impact of amino acid protein intake on more clinical outcomes. And here I'll refer you to a very large, probably the largest trial of its nature, where it's observational in nature. So we're associating a protein intake with an outcome, in this instance 60-day mortality. And in the top row, I basically am asking the question, when I control for a number of confounding variables listed in yellow at the bottom of your slide, what is the impact of achieving at least 80% of that which you prescribe compared to patients who get less than 80% of their protein on 60-day mortality? And in the first column there, you can see the adjusted odds ratio, which is less than 1. So it's associated with a lower odds of death of 0.61. That's statistically significant. Now I can ask the same question with energy. Patients who get more than 80% of their energy requirements compared to those who get less, what's the impact on mortality? And we see an odds ratio of 0.71. So a significant reduction in mortality being better fed or receiving at least 80% of that which is prescribed. On the far right are the same data points, only now in the statistically modeling, I'm adjusting the protein intake for energy and vice versa. So let me explain what I mean by that. If I control for how much energy the patient receives, and I repeat the question, what's the impact of getting more than 80% protein compared to less than 80% protein, I see an odds ratio of 0.66. So still a very large and statistically significant treatment effect with optimal protein intake, even when controlling for energy. However, the same can't be said for energy intake. When I control for protein intake and I ask the question, do I get more than 80% compared to less than 80%, the value there is 0.88 and it loses its statistical significance. The clinical inference from these data are that probably more important to achieve protein goals than energy goals. And I'm not saying that energy isn't important. As I'm illustrating on this slide, though, there may be a threshold effect that beyond which giving more energy, as is indicated by that dotted line that sort of flattens out around 80%, doesn't really impact outcome. In contrast, in our current data set, we don't see such a flattening line with increased protein intake. I've put a few arrows on there, and I'll talk about this later, but current practice is patients are actually only getting 0.7 grams per kilogram. Somewhere there's a guideline that says minimally acceptable lower level might be 1.2, but you can see as we push that up to perhaps 1.5 or greater, there's an increasing beneficial effect on mortality. So we'll come back to that later in the presentation. That's consistent with other studies that show that with increasing protein amino acid intake, that's associated with better survival, as illustrated in this slide as well. It's not just about survival. This slide just reminds you of data that we generated some time ago that shows increased protein intake is associated with reduced infections as well. So at this point, what I'm saying is getting at least 80% of the patient's protein requirements is associated with best outcomes from a patient's point of view. But then you're thinking of, well, what about those large-scale RCTs that compare different doses of protein that don't show a difference on outcome? For example, this one, the Eden trial. You're familiar with this. I'm not going to go into it in detail. You'll be reminded that the focus here was on different caloric doses. They didn't actually report protein intake in the paper, but you can imagine, since there's a fixed amount of protein and calories that hang together in these solutions, that the one group, the trophic-fed group, received a lot less protein than the group that got full-fed. And as you recall, there were no significant differences in any of these outcomes: mortality, infection, time to discharge alive, etc. And it has led many U.S. practitioners to trophic feed for the first 5 days or whatever. They're not that keen, or they're not that aggressive in meeting the nutritional requirements of their patients. And my response to that is to look at the long-term outcomes of these different patient groups. And fortunately, in the Eden study, their investigators did follow these patients for a year, documenting their physical and cognitive function. And I suspect that you can't read all the details on this slide. I want you to just appreciate that they did a number of physical measurements and cognitive assessments, none of which were statistically significant. You can see that by the 95% confidence intervals all crossing the line of unity, but all quite wide. So they lacked statistical precision to really rule out an important treatment effect. For example, if you look at the top two measures there, the 6-minute walk test or the 4-meter time walk speed, which I think are two of the most important physical assessments, 90% of the 95% confidence interval lied to the right, which favors full feeding. I'm showing you the p-values in that inserted bar there. They're not statistically significant, but this is certainly consistent with a trend towards improved physical recovery a year later if you were full fed. Or said differently, if you were underfed systematically for the first 5 days, your physical recovery was hampered by your nutritional strategy, even at a year later. This was confirmed, if you will, by another paper that we published last year, where we looked at a subset of survivors from the redox trial, where we followed these patients up to 6 months, documenting their health status using the SF-36 questionnaire, which basically can be broken down into a measure of physical function, role physical, and then sort of a summary physical component scale. And so what I'm showing you on the slide are data from that study, where we created a regression model that said, you know what, for every 25% increase in the nutrition provided to these survivors, what effect does that have when we control for these important confounders listed on the bottom of the slide? What effect does that have on their SF-36 scores? Remember, a higher score is better, or a better outcome. And so at 3 months, we see both a statistically significant and a clinically important increase in the score in their physical function, role physical, and physical component scale. Now, we lose the statistical significance in 6 months, but the signal is still there. It's just an issue of numbers and statistical precision. So what these data also suggest is better fed patients who receive more than the next guy, have better physical outcomes long term. There's some unpublished data done by a colleague of mine from Australia, where she's used the ultrasound of the quadricep, measuring that thickness. That's the y-axis, and days over time on the x-axis. And you can see the 0 mark there near the middle, which marks the transition from end of ICU stay to the ward. She's characterizing that loss of muscle mass as measured by this ultrasound in this patient population with traumatic brain injury, that sort of decreases, or at least is attenuated at discharge from ICU, and then slowly, maybe begins to increase, or at least stabilizes over time. And what I found really interesting as well was the fact that she was able to correlate the quadricep thickness at hospital discharge with these outcome measures, both the SF-36 and the Glasgow outcome scale, that looked at functional endpoints at 3 and 6 months. Again, suggesting that the amount of muscle that you have impacts on outcome, and therefore, with the question being, with our nutritional strategies, can we preserve that muscle mass and improve the patient outcomes? Or said differently, if we continue to underfeed our patients, that may be harming some of them reducing their speed or their timeliness of their recovery. Let's give consideration to one other important large-scale trial published recently, which is using intravenous amino acids as the way of providing extra protein. These patients were standardly receiving enteral feeds, but on top of that, they were topped up, if you will, to about 2 grams per kilogram per day using intravenous amino acids. The overall goal of this trial was to actually prevent kidney injury in patients at risk of acute kidney injury. And so there's a lot of stuff that's why the trial is called the NephroProtect study. And the overall endpoint then was this, looking at, this is just showing you the difference in protein intake. So they're getting close to 2 grams per kilogram per day. And I must say, in our International Nutrition Survey work, we rarely, if ever, see that kind of dosing actually achieved in real practice. More commonly, the red line represents real practice, where we're down in the 0.5 to 0.8 grams per kilogram per day. And again, I'll show you some INS data on that in a minute. But so they did achieve good separation in groups in the amount of protein. However, they had trivial effect on the glomerular filtration rate, which is the primary endpoint. But along the way, they measured a number of other renal endpoints, such as use of dialysis, and clinical endpoints, including mortality and quality of life. And really, there were no effects of this extra amount of protein amino acids, which confuses us and makes you wonder about what I just said a few slides back, that more protein actually impacts on the outcome. So how do we put this all together? And I think it comes back to this slide, which I think I borrowed from Kathy many years ago, that not all ICU patients are created equal, and so we shouldn't necessarily expect that nutrition will have the same impact on all ICU patients, or said differently, that not all ICU patients will suffer or be harmed by underfeeding. And that's the problem with our randomized trials, is they do treat all patients the same. They enroll these heterogeneous groups of patients into these trials, and as a consequence, you have some responders, some non-responders, but the overall effect is nil. But I want you to sort of just step back and think about this concept, and look at these two patient phenotypes on this slide, and ask yourself, do you think the effect of treatment, nutrition treatment rather, will be the same in these two phenotypes? A youngish patient with normal or maybe supernormal lean muscle mass who has a relatively short-term stay in your ICU, in contrast to an older patient with frailty and significant comorbidities, likely sarcopenic, with a protracted illness that includes periods of time where she's acutely undernourished prior to coming to ICU, and then intubated and has a long ICU stay. So I don't know, I would say that I don't expect nutrition to impact the outcomes of these two patient groups the same, and so we need to be more sophisticated in our attempts to do nutrition risk assessment. I will say that all existing nutrition screening or malnutrition screening tools are inadequate in the context of critical illness. None had been validated in the context of critical illness, and that led us to step back and say, okay, maybe we need a new tool. Conceptually, building on the work of Gordon Jensen and others, we think of nutrition as a function of both starvation or undernourishment in the one instance, and inflammation or severity of illness in the other instance. And so on the current slide, I'm showing you our conceptual framework for developing the Nutrix score. I'm going to go through this stuff pretty quickly because I think most of you have heard of it. I want to get to the slide where we give you an update on where things stand with respect to the Nutrix score. So here are the components that go into the Nutrix score. It's a function of age, Apache score, SORFA score, comorbidities, days from hospital to ICU admit, and the IL-6 level. You'll recognize that the nutrition history variables, things like history of weight loss or history of reduced oral intake, are not in the Nutrix score. And not to say that I don't think they're important. I still seek for those data points, and I would still incorporate them into my nutrition risk assessment. But in this statistical modeling that we did, there was so much missing data, there's no way it'll come out as significant. what we've been able to show, and this is the most important slide that you understand as it relates to the Nutric work, is that there is a different relationship between nutrition intake and outcome based on your Nutric score. The x-axis here being nutritional adequacy, the y-axis being 28-day mortality, and then each of those lines represents a cohort of patients with a particular Nutric score of 1 or 2 or 3, as you move up the bottom of that slide. And as you look at those lines and move to the right, where we're trying to show with increased nutritional adequacy, there is no change in the 28-day mortality. In contrast, with the higher Nutric score patient groups with increased nutritional adequacy, it's associated with a reduction in mortality. So we've gone on now in 3 separate databases, including our International Nutrition Survey database, which included over 200 ICUs, to validate that prior concept that Nutric seems to be able to discriminate patients who will benefit the most from more nutrition, i.e. those high Nutric score patients, or said differently, patients who will be harmed the most by ongoing inattention to meeting their nutritional requirements. I really want to stress that the Nutric score has been validated without the IL-6 levels, so that shouldn't be a barrier to uptake. I know that one of the biggest barriers is getting Apache scores and SOFA scores on your patients, and I can't excuse that. I mean, I just know it takes effort to get it. It's required to sort of quantify the severity of illness. We have put tools up on our website and links to other Apache calculators to help in that process. So I know that that's one of the challenges you have, but that it is what it is. I will also just like to mention that it's been translated and validated in other languages and other patient populations, but it also has been challenged by a post hoc analysis of the PERMIT trial. I don't know if you're familiar with the PERMIT trial, but it was a randomized trial of different doses of calories that didn't end up showing a difference of different caloric intake. So in a post hoc way, they went back and said, whoa, maybe in the high Nutric patient groups we can show a difference of caloric intake, and they could not. But I'll just say briefly that there are very wide confidence intervals around those point estimates, and so it was really an unpowered post hoc subgroup analysis. And more importantly, and to the point of today, we think protein dosing is more important than calories, and so I still think it's an open question that needs to be further validated by prospective studies, that more protein does impact the outcomes, but excuse me, more in the high Nutric patients than the low Nutric patients. So at this point, I just want to consolidate what I'm trying to say by asking the question, well, who might benefit the most from our protein interventions? And their answer being high-risk patients, which includes high Nutric score patients. I'm not trying to say that just high Nutric score patients will benefit from our aggressive use of artificial nutrition. There's other data that point to patients on the extremes of BMIs or patients who have really long stays. And I still want to include patients who have the traditional diagnosis of malnutrition also benefiting more. And I open the issue of whether patients who are sarcopenic or not, they might benefit more than non-sarcopenic patients, but that still is an open question because of our difficulties in defining and finding these types of patients. So at this point, optimal nutrition is associated with the best outcomes, but probably restricted benefit just to those patients who are at high risk. So let's just open this up a little bit as we move into a discussion about current practice. Let me ask you, using a polling question, you'll be able to respond here in a minute. What do you see, what do you usually target as the protein dose for your average ICU patient? If you could select one of the answers, 1.2 to 1.5, 1.5, 1.5 to 2, 2 or greater than 2, I'll just give you a minute here to vote, and then we'll post the answers and have a discussion about that. Okay, if we could sum up the vote there and present the answers. So our audience on average sees the target dose of 1.5 to 2 as the most common response, 52%. Very few people hitting higher than that. Quite a few people hitting lower than that, 1.5 being a very common answer and 1.2 to 1.5. Okay, let's move on and show you from the International Nutrition Survey. I'm just trying to move the slide forward. There we go. Oh, sorry, now I went forward, too far forward. Okay, so as you are, I'm sure, all aware, the Aspen guidelines recommend 1.2 to 2.0, but there are experts that do recommend some subgroups of critically ill patients. And so when we survey the world, and there's over or almost 186 sites that contributed to these data, you know, you see that on average patients are actually only being prescribed 1.2 to 1.3, maybe up to 1.5 in some sites. And then modular protein supplements. Just so the majority of them. There you go. Whoops, I went too far. To that poll. Okay, can we see the answers? So most common response 3 times a day, some up to 4 times a day, some as low as once a day. Okay, great. Well, I mean, you Canadians, you do things awesomely. Oops. But these data come from worldwide practice, and I'm sorry I don't have that broken down by Canadian practice standards. You know, there's always a difference between what we say we do and what actually gets done. And so as you know from the INS data, these are actually what's happening. So as I told you, patients are being prescribed on average 1.2 grams per kilogram per day, and they're only receiving about 55% of that on average. So about 0.7 grams per kilogram per day is what people are actually getting. And from what sources? And so on the right side of that slide, I've broken that down to patients getting most of it from enteral nutrition, which makes sense, but very few percentage points, speakingly, are they getting it from protein supplements. And that's a puzzle to us a little bit, given that we've been pushing protein supplements in the context of the PEPA protocol. So I think there's a lot of room for improvement in using these other tools such as protein supplements, parenteral nutrition, and intravenous amino acids as well in some cases. This slide further worries me a little bit. In the same data set, looking at INS data, only about 16% of patients globally are getting about 80% of what's being prescribed to them. Within a site, if I look at site level performance, only 6% of sites consistently achieve that goal in 80% of their patients. But most importantly, what worries me is that the performance is the same in high nutric patients. So if I focus down on high risk patients, I don't see any change in performance, as if to say practitioners aren't really discriminating between high and low or average. They're treating, you know, their systems are set up to treat all patients the same, and so we're not achieving better results in our high nutric patients, which I think is a concern to me. So I think I would answer this question, no, we're not providing adequate amounts. We need to do better. Perhaps our traditional protocols are sort of part of the problem in that we start low, we advance slow, we check a low gastric residual volume which holds up the feeds, and we don't use these other tools such as protein supplements to enhance at least protein delivery. I'm sure you're all familiar with the PEPA protocol. but in the context of that PEPA protocol, we are recommending the prophylactic use or the preemptive use of protein supplements. And I liked that I saw many of you are using those, 3 or 4 times a day to ensure that we do get up into that protein adequacy range early on. I can say that as we've implemented the PEPA protocol, we still do see problems with administering protein supplements. Either they're not delivered or they're not recorded that they were delivered, so it's hard to abstract that data when we come to create these kinds of figures. So we still see room for improvement, either by giving more of the protein supplement or making sure that it gets delivered or making sure that it's documented. So heads up on that documentation point. I think that's an issue for many sites. What I want to make in this slide, though, is really trying to avoid the patients starting out MPO, because you'll never catch up and achieve that success with 80% by day 3 if patients start on MPO. But if the patients are started on volume-based feeds, that's the top line in light yellow or maybe beige, that by day 3 they're getting 80%. So the volume-based feeds concept, the volume-based feed plus protein supplements for sure will be a strategy for success, avoiding MPO and avoiding trophic feeds, because you'll never make up for the deficit. We also learned from PEPA that it's not just about volume-based feeds or maximizing delivery. We have to engage with our colleagues to minimize the interruptions, which now, more so than gastric residual volume increases, this is the main reason why people don't get adequate amount of nutrition. And so to work with anesthesia, surgery, and your critical care teams to minimize those interruptions. And we've got an example of said protocol on our website that you can take down as a starting point for those conversations. Let me also just briefly flag the role of supplemental parenteral nutrition. We just finished an RCT called the Top-Up Study. It's under review at Critical Care Medicine. I'm just showing you one slide that shows you how much calories and protein they got via the enteral route, because both groups were fed enterally and achieved about 60% of their protein requirements via the enteral route. And the goal of the Top-Up Study was to top them up with supplemental parenteral nutrition. So you can see in the bottom set of numbers up to a 22% increase in protein during the week of the intervention was achieved by giving supplemental parenteral nutrition. And I suppose the same could be said by just giving supplemental amino acids. Just topping them up to that 2.5 grams is the way forward. So let me summarize what I think should represent your practices in awesome Canada, who are good nutrition specialists, that you're using a PEPA protocol or something like unto it that really proactively delivers our best nutritional strategies from the get-go, that does initiate the enteral nutrition within 24 to 48 hours automatically, like part of the admission order set. The nutrition gets ordered, nutrition gets delivered and optimized, and then you come along on day 3 and say, hey, are we getting 80%, yes or no? And if yes, you pat yourself on the back and say that's great. And if not, you have to give some consideration to, is this a high-risk patient or not? Because if they're not, don't stress over it. It's not that important, as evidenced by the Eden and the Permit trial. I would keep following those patients because they may evolve into a high-risk patient group. Oh, that's really unfortunate, working at home when the home phone rings. Sorry about that. What I'm trying to say, though, is if they are high risk, you'll want to maximize the intake with motility agents, small bowel feeds, or protein supplements. And then if that's not working, earlier than later, consider the role of supplemental parenteral sources of substrate, either intravenous amino acids or parenteral nutrition. So I just want to close reviewing what I've said so far, that preserving muscle mass and function will facilitate an optimal recovery of our patients. I'm concerned that I think we're both dosing people on the lowish end and that we're under-delivering protein, which I think is resulting in patient harm. Okay, not all patients are being harmed, and that's why we had that conversation about Nutrix scores and nutrition risk assessment. But I do think there are strategies that help with increasing the amount of protein we can deliver, and I've mentioned a few of them briefly. Certainly Kathy is going to sort of come on in a second here and speak more to about a protocol and a product that also is helpful. Let me just remind you of our nutrition survey work, and that let you know that in April of 2017 we'll be starting again, so watch our website if you're interested in further documenting how much nutrition, how much protein your patients are actually getting. Thanks for your attendance, and I'll come back on when we have some questions. Let me turn the time over to Kathy now.
Thank you very much, Dr. Hyland. Today I wanted to zero in on one method of increasing protein delivery in the ICU that Darren just mentioned, and that is through the use of a very high protein formula. I do have one disclaimer today, and that is that I'll be presenting the results of an observational trial that we conducted at 6 different sites in Canada, and Nestle Health Sciences supplied the formula for each of those different sites. So I'm going to start off with a polling question. The first question is, are you using a higher protein EN solution? And I know some of you are currently asking, what do you define as higher protein? And that's something we're going to discuss as we go along. So I'd ask you to please make one selection, and we'll carry on. And I see that the large majority of you are using a higher protein EN solution, so about 85% of you. So certainly what I expected, and that's something we can discuss as we go along. Despite all of the evidence on the benefits of protein in the ICU that Dr. Hyland just covered, and all of the efforts that each of us are working on to achieve those protein goals, there continues to be a gap between what protein is being prescribed and what is being delivered in the ICU. We're failing to meet that 80% target. So one of the solutions is to design and to deliver a higher protein enteral formula with a lower non-protein calorie to nitrogen ratio. This allows us to deliver adequate protein without exceeding caloric requirements, and in particular carbohydrate requirements. So the next polling question is, if or when you're using a higher protein EN solution, and 85% of you are, which of the following are you using most often? Are you using a formula with about 18% of calories from protein, 24 to 25% calories from protein, or one that provides about 37% calories from protein? I'll just ask you to quickly make a selection, and we'll carry on. All right, so the majority of you are using a formula that has about 24 to 25% calories from protein. Not unexpected, and this actually provides a very nice segue into presenting the results of our trial. Our study was designed to determine if a specialized enteral formula that had 37% of its calories from protein, so it was a 1 cal per mil formula which delivered 92 grams of protein per liter, we wanted to demonstrate that this formula could deliver at least 80% of prescribed protein needs to critically ill patients. And we looked at this for the first 5 days of feeding. This was a quality improvement project. Patients were thought to require enteral feeding for up to 5 days, and they were recruited from 6 different Canadian ICUs. There were no guidelines for the dietitians. The dietitians at the 6 sites chose which patients they felt were appropriate for this type of formula, and there was no guidelines with respect to nutritional assessment for protein or energy. We did ask the dietitians to collect some data, the first one being the rationale for choosing this very high protein formula, and also we wanted data on the patient's BMI, their protein and energy targets, and then we looked at percent protein and energy delivered on each of the 5 days when patients received the formula. We were also looking at data on feeding interruptions, and as this was the first time this formula was used in Canada, we wanted some information on the general GI tolerance of the formula. So the results from the 6 different sites, each site enrolled anywhere from 3 to 12 patients for a total of 49 patients. And we had data on 44 of those patients. We felt it appropriate to only include patients that were receiving the formula greater than or equal to 2 days. So of the patients, those 44 patients, what we were looking at is, were we able to achieve greater than 80% of prescribed protein needs? As you can see on day 1, we were not. Darren would probably indicate they should have been on the PEP-UP trial or PEP-UP protocol. It looks like most were on a more traditional feeding schedule. However, on days 2 through 5, you can see that patients received anywhere from 75 to 83% of their protein needs. So average protein prescribed was around 1.9 grams per kilo. Average protein intake was actually more like 1.6 grams per kilo. So we looked at this for energy as well. Again, day 1 it was lower, but days 2 through 5 we achieved anywhere from 71 to 83% of assessed energy needs. So about 300 calories shy of what the dietitian prescribed on each of those days. We also wanted to determine what the primary reasons were for choosing the formula. The numbers exceed 100% because dietitians could choose more than one reason. And you can see that the primary reason cited was for obesity, followed closely by patients that were had an intake of propofol. Other reasons were trauma patients, septic patients, or patients on CRRT where protein needs are higher. So what we did then is we looked at the 2 most cited reasons for choosing the formula and compared, for example, the obese patients being the most cited reason. We compared that to the non-obese patients. The obese patients are the red bar, the non-obese are the gray bar. And you can see on days 2 through 5, obese patients compared, I think we can say compared to non-obese patients in terms of the percent of protein delivered. Same holds true for propofol, that being the second reason why dietitians prescribe this formula. If you look at days 2 through 5, the propofol patients compared to the non-propofol patients, anywhere between about 75 to 83% in terms of percent protein received. 37 of the 44 patients did not require any supplemental protein. So that's about 84% of our patients. And without supplemental protein, we were days 2 through 5 able to achieve the majority, or I should say most patients received more than 80% of their prescribed protein intake. We asked about feeding interruptions, the number of times there were interruptions, and also the reasons for feeding interruptions. And as you can see, the primary reason for feeding interruptions was not an intolerance reason, it was for fasting for procedures. And Darren alluded to that. It does concur with the International Nutrition Surveys and is being looked at closely by practitioners in ICUs around the world as to what can we do to reduce the amount of time that ICU patients spend fasting. But as you can see, the GI intolerance was about 6% of the total reasons for feeding interruptions. So specifically, formula was well tolerated. 86% of patients had no GI symptoms. One patient died during the data collection. Of the remaining 5 patients, less than 5% had issues with constipation, and about 7% of patients had issues with diarrhea. So when we look at strengths and limitations of the study, I think the primary strength is that this is real-life experience of Canadian clinicians. There were no rules set as to which patients to select and how dietitians might use this formula. And it does confirm that we are able to meet higher protein needs enterally without the use of modular protein. Obviously, the limitation, the primary one, is the small sample size. This data is from 44 patients. It was an observational trial, so there's certainly no cause and effect intended. And energy needs were estimated using predictive equations rather than through indirect calorimetry. So certainly we would need a larger trial to explore the impact of protein delivery in a little more detail. So I just wanted to present one case example, and I just have one slide on this. Since obesity was the most common reason cited for choosing the higher protein formula, I wanted to show how we might use this formula for an obese patient. So it's the example of a patient with a BMI of 48, admitted to ICU. Ideal body weight is about half of what actual body weight is. It's always debated as to how we should assess these patients for energy. I've given a few different examples based on the ASPEN and SCCM guidelines. And for this patient, it ended up being somewhere between 1,300 and 1,600 calories. Protein, you could use again these ASPEN guidelines if we're using 2 or 2.5 grams per kilo, very high protein needs. So how would we achieve this? I've provided 2 options. Option A would be using a standard enteral formula with protein modules, and I know you all have access to different formulas and different protein modules. I just gave an example of one way we would deal with that in my local ICU, just using a 1 cal per mil formula, the highest protein formula we have, which I believe up until a few months ago was about a 25% protein formula, and then add protein modules. In this case, I would have added 6 to 8 times per day. So consider the nursing time to mix each of those modules with water. They have to flush pre and post. They have to administer it. They have to chart. On that administration, you know the difficulties Darren cited with charting. That patient might be on isolation. You essentially have to double the nursing time if a patient is on isolation. It's an option, and certainly we do this kind of delivery all the time. A second option, however, would be to use this specialized enteral formula with 37% protein and doing the calculations at 60 mils an hour with no additional protein. You'd be able to meet this patient's energy and protein needs. I wanted to briefly mention a recent Canadian ICU nursing collaborative. Nurses have identified sleep deprivation in the ICU as one of the primary causes of delirium. Delirium having significant impacts on not only length of stay but on patients' quality of life during ICU, after ICU, and long-lasting impact even after the patient goes home. There is a priority in Canada right now to promote sleep in the ICU and minimize patient interventions between, well, in our ICU it's for 8 hours overnight. And they're asking us to avoid Q4H and Q6H hours when possible overnight in order to promote sleep and hopefully to prevent delirium. When we audited our ICU, one of the major reasons nurses went into a patient's room at night was to do a protein delivery or a protein bolus. This specialized formula is ideal because it would prevent the need for the nurse to go into the room several times overnight. So just working with the team to see what we can do, not only for nutrition, but for delirium prevention as well. So my conclusion today is that a specialized EN formula with 37% calories from protein, 92 grams per liter of protein, is well tolerated and will help to achieve higher protein targets in critically ill patients. And just some acknowledgments today, first and foremost to Bethany Hopkins, who has set up the 6 Canadian sites for the pilot study and recruited the RDs to participate, and of course to the 6 different participants and participating sites for the valuable information provided. So I think with that we will conclude, and I will hand the microphone back to Bethany. Thank you very much for your attention.
Thank you, Dr. Hyland, and thank you, Kathy. We have a little bit of time left. We have a few questions, and one question I have here that I want to throw out is, are there any contraindications or groups of patients to exercise caution when dosing higher protein in the ICU?
Did you want to start with that, Darren, or did you want me to begin?
Go ahead, Kathy.
Okay. There are certain groups of patients where you would be cautious. I gave the example of, in this particular lady, where we'd be dosing 2.5 grams per kilo. Certainly that's not for all of our patients. If there's a patient with chronic renal failure who there's no dialysis intended at any point in time, you certainly wouldn't want to dose those patients with this very high protein intake. And I think too, just thinking of Darren's Nutric score, not all patients need that extremely high protein intake. They may be fine with 1.5 or 2 grams per kilo of protein. I'm not sure if you want to dispute that, Darren, or add to that.
No, that's fine.
Okay. Now, I'm looking at the time and cognizant of our schedule, and we're actually out of time. Our 1-hour webinar has come to a close. So I want to thank you once again, Dr. Hyland and Kathy, for your presentations today. And I want to thank everyone in the audience for attending our webinar. And one last reminder to those in the audience to download the handouts and certificate of attendance using your control panel. You will receive a short survey, and we would appreciate your feedback. And you will also receive a follow-up email within the next week, which contains a link to view the recording of today's webinar. And so on behalf of Nestle Health Science and our presenters, thank you for joining us today, and have a great rest of your day.